All right, well, seeing as it's 3:02, we will go ahead and get started. Welcome everyone to our pilot kickoff for the Care of the Late Preterm Infant Project. We are so excited that you're here and excited to pilot this project with you. And so I will hand it over to Brenda, who is going to give us a back for the Thrive Bundle and this project.
Everybody, again, thank you so much for joining us this afternoon on May the 5th. So happy Cinco de Mayo and happy Mother's Day coming up this weekend as well. This is a bundle that we put together with our leadership and talked with other states, really about a focus on the nursery and the level 2 NICU, but you will see our projects will be very valuable for different NICUs and different areas that you're looking at. The first one that we are tackling is the care of the late preterm infant. And you may remember we had a project on this a few years back. We looked at only 35, 36 weeks. So this time we're hitting the whole late preterm, and we have a great project for you. And we will have potentially all 5 of these projects. And you can see there's a safe to sleep one that we've done before and is always super enjoyed, appreciated. We also have a breastfeeding one that also have a lot of enthusiasm for. Relational health would be a great one to do, and we hope that we can combine that when our maternal colleagues are working on that. And then hypoglycemia, we'll dive into a little bit more, but really excited that you're piloting, helping us to look at this project and how that we can continue to improve care and help us to know the project, the data, it all makes sense, what else we need to be looking at as we roll this out across the state. So thanks again for joining us. Thanks to all of our leaders as well for helping to direct and spend all their time and effort to roll this out across the state.
Thank you, Brenda. So we have a wonderful agenda scheduled for you all today. First, we are going to do a brief introduction to the Late Preterm Infant Project and what we're looking for in this pilot phase. Then we are going to do on potentially better practices and the project toolkit. And then Alicia is going to walk us through the data aspects of the project, what that means for you all, and we're even going to do a little introduction to our platform, Simple QI. And then we'll get into some of the logistics and future steps at the end. This is our late preterm infant faculty. You will get to hear from the majority of them today. Thank you all for your continued leadership and development of this project. Patty isn't here to join us today, but I know she is with us at heart, and she is our QI specialist. So I will turn it over to Dr. Scazzino.
Okay, thanks, Anastasia, and thank you all for joining us. We are excited to start this pilot project so you can help us to refine this effort and roll it out statewide this summer. So welcome. I'm just going to speak briefly about why this project is important. We all know that late preterm infants have unique risks, and these include risks for complications during birth and the birth stay, increased risk of need for evaluation or interventions, increased risk for separation of mom and baby that may impact their course and outcomes. We also know that they're at increased risk of being readmitted after discharge home early on after discharge after birth. And that's something we definitely want to prevent. They've also been known as great imitators because they are just late preterm, so they're close to term, and sometimes they look like term babies, but we have to remind ourselves that they're not, that they have immature development, things like suck, swallow, breathe coordination is not fully developed. They'll have more difficulty maintaining temperature, maintaining blood sugar, and again, at risk for setbacks during the hospitalization. And research suggests that these risks increase with lower gestational age. Fortunately, we do have effective evidence-based approaches that we know can improve outcomes for late preterm infants and prevent complications and prevent those early readmissions after birth discharge. So we, in our great team of state leaders for this project, have assembled all of this into a toolkit, which we're going to review with you all today. So thanks for being here.
Thank you, Dr. Sketsina. So as we have mentioned, this is our pilot phase. And so the following hospitals are our pilot teams with representation from rural and larger facilities throughout the state. So we are at different stages of the application process for each of these. So I'll be following up with each of you based on where you are. But if you have any questions, feel free to reach out to me. This is our tentative timeline for the pilot phase. So obviously we're kicking off this month with our pilot launch, and then we will have a pilot huddle in June, and then aiming to go statewide in July. And then currently looking at sustainment in June of 2027. So I'm hoping for a statewide implementation that is a year long for this project. And during this pilot phase, we are hoping that you all will provide us with feedback on the project, on the resources, on the data, so that we can improve and make this a seamless project for a statewide launch in July. So what that means is continuing to attend our huddles, reviewing the toolkit and the resources that are linked in TIPQC and on our website, and then provide us feedback. Is there anything that didn't quite make sense when you were implementing it? Anything that you needed further clarification on? Anything that wasn't sitting quite right? So just review those resources. Let us know if you run into any barriers, as well as the full toolkit and the key driver diagram, which we'll look at in a little bit. And then with data entry, as you get into TIPQC and as you are implementing the data and inputting the data, just let us know how that's working and if there's anything that needs improvement on the resource side. And so it looks like many of you have completed multiple TIPQC projects already, but just in case, just a few general reminders of a TIPQC project and the structure. So we will meet monthly as a collaborative where we will look at the team's progress, we'll review collaborative data, and then we'll hear from each of our teams. We're hoping that you all will report out your progress, what you've been working on, and about a 3-minute report, which we'll get into in more detail. The huddles are set to meet the first Tuesday of each month at 3 o'clock Central, 4 o'clock Eastern. That's the huddle, the pilot huddle schedule, as well as the statewide collaborative schedule, so it won't change come July. And then that you'll meet internally with your team to actually look at these resources and implement this project on a monthly basis, as well as inputting your data on a monthly basis. As far as quarterly expectations go, we're hoping that you'll schedule a coaching call with TIPQC on a quarterly basis so that we can touch base, discuss any barriers you're facing, look at where you stand in the project metrics, as well as submit your quarterly data into TIPQC. This is a little flyer we have. If you are recruiting more team members, you're welcome to use it. It just says kind of what we went through in the last slide on the different expectations and what participating in a TIPQC project actually means. So if you have any questions, feel free to reach out to me. I am available, but we are so excited to launch this pilot phase with you all today. With that, I will hand it over to Dr. Gutman to provide a brief overview on the project.
Hey there. So our state project aim will be to improve the care and outcomes for infants 34 and 0 to 36 and 6, the late preterm infants, by systematically implementing evidence-based practices to improve consistency across the state, to ensure stability at the time of discharge by achieving the completion of an appropriate readiness checklist for discharge, for at least 90 to 100% of discharged late preterm infants by June of 2027. So this is our state aim, and we hope that it can lead you to adapt it for your hospital and your specific nursery to come up with your own team aim. Our target population is all late preterm infants between 34 and 0 weeks and 36 and 6 weeks gestation, as categorized by the AAP as a late preterm infant, who are cared for in a hospital's newborn nursery or NICU. From the Department of Health, a level 1 facility can care for stable term newborn infants and infants born between 35 and 37 weeks gestational age who remain physiologically stable. So some of our late preterm infants may be able to stay in a level 1 NICU or a level 1 nursery. These facilities can stabilize ill newborns and those born less than 35 weeks gestational age until transferred to another site that can provide the appropriate level of neonatal care if they're a little bit earlier or a little bit sicker. These are our potentially better practices or our interventions that we'll focus on to affect our primary drivers. They include parental support, specifically for discharge readiness, infection assessment and prevention, nutrition for the late preterm infant, assessment and stabilization, and jaundice and thermoregulation.
Okay, each one of us are now going to go over each specific parental better practices. The first one is parental support and discharge readiness. So primary caregivers, which could be the parents or any person who the baby is going to be going home, must transition from observers to primary caregivers. They need to promote positive relational health throughout the structured family-centered care models. The way that this can be done is by direct care and physical involvement, which includes skin to skin or kangaroo care, active care participation, supporting and enhancing NICU sensory experiences, such as like reading to the baby, talking to the baby, again with the skin to skin. Beads of encouragement. These are ways to celebrate milestones where such as being off respiratory support, the first bath, first bottle, open crib every week of the baby's life, just some positive reinforcement. The next aspect is enhanced communication and education. These are having family-centered medical rounds, including the caretakers when possible, virtual update platforms like telehealth platforms or Angel Eye, and just educating the parents or caregivers of just common words and equipment in our lingo, but making it so much more understandable for them. The next aspect is environmental adjustments, providing intervention to prevent social risks to having a baby in the NICU. This would include transportation for families, providing gas cards, meal tickets, and just a nurturing surrounding. For discharge readiness, the big key is that the late preterm infant caretaker is actively participating in their infant's care the last 24 to 48 hours of admission. And this can be seen at the bedside, participating in each feeding and care time, or participating in a rooming in environment. At the time that the baby is ready for discharge, the caretaker should receive education on a feeding plan, safe sleep, prescriptions, follow-up appointments, and preventive care.
Next, we want to look at infection prevention. So these infants are at increased risk of sepsis. The rate of a late preterm infant infection is 1 per 1,000 live births. This is due to an underdeveloped immune system, inadequate transference of maternal antibodies, impaired skin integrity, and increased exposure to pathogens, such as through maternal infection, chorioamnionitis, leading to preterm labor. So with a known increased risk of infection, you have increased sepsis evaluations, and antibiotics may become unnecessary in this population as well. So as we're looking at infection, we also want to make sure that we're looking closely at antibiotic stewardship. In fact, these infants carry a 200-fold higher rate of antibiotic use than actual early onset sepsis. So this is a critical co-component of sepsis awareness in this population. We want to evaluate for maternal and infant risk factors closely to see if this infant does qualify for antibiotics to rule out sepsis, or if we can just rule out infection based on other clinical factors. So maternal risk factors include premature rupture, infection. This could again be subclinical infection, maternal fever, and the GBS status and history and prophylaxis of mom. Infant factors could include delivery complications. If the baby's very low birth weight, has congenital anomalies, low APGAR scores, or is a multiple pregnancy. All of these factors lead to NICU admission, which leads to invasive devices, which leads to an increased higher risk of infection. And then for the baby, we also want to make sure that they remain stable after admission. So we're looking for infection on admission, but we're also following closely after admission to the vitals and the clinical status, because this can change as the infant remains at high risk for infection. A great tool that we encourage use for every baby over 35 weeks is the sepsis risk calculator. This is just available on the web, the Kaiser Permanente sepsis risk calculator. This is highly evidence driven and a very helpful tool to objectively determine whether antibiotics are indicated to rule out sepsis, or if you can proceed to evaluate for infection just clinically.
Okay, next I'm going to talk about nutrition for the late preterm infant. You want to develop and share with staff a standard late preterm feeding plan. Now, some of the things we'll talk about are commonly recommended for all infants and for all breastfed infants, but some of these are particular to the late preterm infant, or even more important in the late preterm infant. And so it's important to recognize that LPIs are at risk for ineffective feeding. They are in that higher risk group that you want to screen for hypoglycemia. It's also important to assess their readiness to feed before even initiating oral feeds. And then, as you would for any newborn, you want to support rooming in 24 hours a day as possible. Encourage early and frequent skin-to-skin contact as possible, and observe and validate caregiver knowledge of feeding throughout the hospital stay. And we do have a focus in this project on discharge readiness, preparing for discharge. Other important activities. So if they're ready to feed, then of course it's important to evaluate LPI's coordination and stress level during feeds. As with all infants, having a quantitative, regular assessment of feeding, such as the latch score to look at effectiveness, is helpful. It'll be even more important in the late preterm infant to monitor their physiologic stability, oral intake, stool and urine output, weight change, and then monitor and support mom's milk supply. It's recommended to reassess how feeding is going if there is weight loss of greater than 3% of birth weight in the first 24 hours or greater than 7% of birth weight by day of life 3. There are evidence-based guidelines for supplementing breastfeeding when medically indicated, and that may be with mother's own milk as first priority. And so again, it's important to support mother's milk supply and milk expression whenever supplementing. And, you know, in terms of discharge readiness and feeding, late preterm infants tend to be inconsistent. So I think it's important to have a little bit longer period of observation with them than as compared to a term infant. So we often want to make sure that they're feeding adequately for at least 48 hours prior to delivery. And then 2, that there's a good feeding plan for home. They may be at more risk for needing supplementation, and you want that to be very clear on how to continue that at home for the caregiver. So since Patty's not here, I'm also going to talk about assessment and stabilization of the late preterm infant. It's important from the start to review maternal and neonatal history risk factors that could increase the risk of instability and respiratory distress. So these may include prematurity, various maternal conditions, prolonged rupture of membranes, multiple pregnancy, C-section delivery, certain demographic factors like male gender, labor complications, low birth weight, and hypothermia. It's also important to note the history of steroid administration. When did they get that relation to delivery? Did they get it? And how many doses? And you can see a single course of betamethasone is recommended for pregnant women between 34 and 0 and 36 and 6 weeks of gestation who are at risk of preterm birth within 7 days and who have not received a previous course of antenatal steroids. Signs of respiratory distress could include rapid breathing, grunting, flaring, retractions, oxygen desaturations, or apnea episodes. And again, similarly with feeding, a little bit longer period of observation, you know, really make sure they're going to be consistent and not have any of these signs of respiratory distress before you discharge them home.
Good afternoon. I'm going to talk about jaundice. Our preterm infants are more likely to develop hyperbilirubinemia. Often it's more severe and lasts longer in our preterm infants. This is also one of our biggest readmissions is jaundice. They can develop toxicity and long-term neurologic sequelae at a much lower bilirubin level than compared with your term infants. So what do we want to do on all of our babies? We want to review the maternal blood type and their RH factor, and if necessary, the Coombs. We're going to monitor for risk factors for hyperbilirubinemia and risk factors for neurotoxicity. We're going to assess for the presence of jaundice every 12 hours. Your nurses will assess visually with their assessment every 12 hours or sooner. And then we want to do a TCB, or for those that don't have the transcutaneous meter, do a serum bilirubin between 24 and 48 hours or before discharge. We want to plot those on our nomograms, and the nomograms have been updated in the last few years. We use BillyTool for those 35 weeks and above, and for those younger than that, there is a tool through Stanford Children's. And of course, provide phototherapy if indicated.
Hello, good afternoon. We also know that these grade imposters often can get cold. They have various risk factors for hypothermia. They are smaller, they have thinner skin, they have less fat, the white fat for insulation or the brown fat that has the important regulatory hormones. These regulatory hormones are decreased in concentration and they also just don't work as well. In all that we've been listening to so far today, we know that they have increased morbidities, and that leads to them needing more interventions, and that entails more exposure. And it's very important that we remember to look at the thermostats in our rooms where these late preterm babies are with us, and that means that we want the thermostat to be 72 to 78 degrees Fahrenheit. As we said, they're particularly susceptible to heat loss by various mechanisms: evaporative, conductive, radiant, and what's my last one, everyone? Evaporative, conductive. Okay, we're gonna have a quiz at the end. Given their higher risk, we have to make sure that our babies are protected, and we want to review the better strategies, our PBPs, things as effective dressing and swaddling, making sure again that the room is warm enough, and just always being cognizant of the environment.
And here is our discharge readiness checklist. Don't worry, you don't have to take a picture or be able to see all the tiny letters if you're like me and that's hard. This is all going to be in the toolkit that we will provide. Basically, this is the tool that we will help you adapt to fit your nursery and your needs, or you can use this same discharge readiness checklist to assess every late preterm infant's readiness for discharge. The completion of this checklist will be our outcome measure on Simple QI. This checklist includes all of the PBP categories that we've discussed today: stability, feeding, jaundice, infection, caregiver education, as well as newborn screening completion, follow-up planning, and developmental care. Who has any
Wonderful.
questions?
We know that was a lot, and there's a lot in each of those 6 categories. So you guys, the toolkit has the full information in each of it, and we will dive in as a collaborative into each of these 6 categories as well. But if you have any questions right now, that was a great time to ask. We got our full faculty almost on here, so any questions? All right. Well, we will move on. This is our key driver diagram. You are not supposed to be able to read it all right now because we know that's a lot, but it is a wonderful tool that is available to you all. If you're wondering where should I start, this is a great place to start. You can use these interventions and potentially better practices listed in this key driver diagram kind of as a checklist. Decide what you want to focus on as far as a primary driver as well. So just wanted to show this to you guys so that you know it's available. It is a great tool for participating in TIPQC project, and it is available on Simple QI as well as in the toolkit. And there are so many potentially better practices and interventions that we had to have 2 pages. And then this is our recognition awards criteria. We won't get into this in the weeds too much, but just wanted to let you guys know what you would be graded on at the end of the project. So in order to achieve all 5 stars in this, you will have to hit these different criteria, which is actively participating and attending our monthly huddles, submitting your monthly reports, and then attending your coaching calls. Integrating a patient and family partner into your quality improvement work. We'll dive into this more, but some of you have listed a patient and family partner in your REDCap application, which is wonderful. But if you have not yet identified a patient and family partner, that's totally okay too. We can identify someone after we officially start the project, and I am happy to provide more details on what that looks like and how to get them onboarded. And then, of course, improving on your process and structure measures is one of the recognition awards criteria, as well as your outcome measures. So we'll dive into this a bit more, but just wanted you guys to see it and know it's available as well. And then as far as resources go, we have quite a few. They are all listed on SimpleQI as well as on our website currently. So if you need the link to the toolkit, you can go to the late preterm category on our website, and we can link it in the follow-up email as well. And then our faculty is a resource for you as well. If you have questions, I'm happy to connect. And then Alicia and I will be releasing some tutorials on how to actually enter data into SimpleQI and how to complete your status report. So those will be recorded so that you can reference them at a later date, but we will get those tools to you as well. And then if you're at the annual meeting, you hopefully grab some of these posters for your hospital. The virtual version is also on our website. Just gives a brief overview of the project. Great tool to get more people involved in your project as well, because it does touch on the project aim, why it's important, and what we will actually be working on. Any questions on any of that information? All right, I will pass it to Alicia to go through the data requirements.
Thank you. I'm super excited to be on this project with you all. On my next slide, I'm going to show you. So basically, there are two time frames that you're going to measure data in for this project: quarterly and monthly. So our quarterly measures are structure measures, so things that you're doing in your organization, and we'll go through that in greater detail. And then also education. So you want to make sure you're doing education with all of your staff. So that's something you update quarterly as well. And then monthly, our process and outcome measures will be in SimpleQI, which I'll show you in a minute. The nice thing about this platform, SimpleQI, is that you can view your data real time. As soon as you enter it in, it's in there. It creates a pretty little graph for you, as I'll show you. You can view your own data, and you can view collaborative data. You won't be allowed to view other teams' data, but it's a really simple way to make graphs for you. And then we'll send you monthly reminders, or, I'll send you reminders if your data is out of date. So don't even worry about that. But, it's just a really easy way to enter in your data. Next slide. So the outcome measures. So Dr. Gutman already mentioned this. Really the only outcome measure for this project, which is a big one, is the % of infants discharged with that discharge ready checklist. So we know it's going to take some time to build that up in your system, but the goal is 90 to 100% of the patients that you're discharging. We do have an optional measure if you want to or are able to do this, and that would be LPI readmissions. I can show you how to create that. I think I've already created it in the system. That's optional though. You do not have to do that. We are disaggregating this by race, ethnicity, and payer status as well. We do want to look for any gaps in care with all of our projects. So that is something else that you'll be recording monthly. Next slide. The process measures are really built into the discharge readiness checklist. So it's really nice. You want to look at your the % of infants receiving human milk, offered lactation consultation, and that can be from many different staff members, and that's more detailed in the toolkit. Dr. Schetzine already mentioned that written feeding plan is really important, so that's another process measure as well. Infection assessment that Dr. Gutman touched upon, and then hyperbilirubinemia. Yes, I got it. That's another one that Dr. Cryer mentioned as well. So these are all parts of the discharge readiness checklist, but they're also part of your process measures. And we'll be collecting that monthly. You will not be disaggregating that by race, ethnicity, and payer status, but we do ask that you put that in monthly based on your monthly census of the infants you're discharging. Next slide. Education. So it's really important with all of this that the providers and nurses are educated on this discharge readiness checklist that you will be implementing for the LPI infants. So again, that's just something you'll be collecting quarterly. So quarters are January through March, April through June, etc. So that's just something you'll enter in once every, or sorry, 4 times a year. So it's not very, very much. Next slide. Structure measures will be specific on having those, policy and procedures in place, the discharge requirements, and also focusing on those written feeding plans at discharge as well. And then also having your patient family partner that Anastasia touched upon. So again, these will be entered in quarterly, very easy and straightforward, and I'm going to show you how to do that. Next slide. Okay, I think we have time. Do we have time, Anastasia? I'm going to show you all Simple QI. I think a lot of you, you've mentioned you've been in these projects. So I will share my screen with you. You should recognize this beautiful website. This is our TIPQC website. If you go to data login in the corner, you're going to see you can have REDCap and Simple QI as an option. You're going to see, okay, these are all the projects that we're working on right now, but you want to go to late preterm. Now I'm probably already logged in, so it didn't take me through the login screen and all that because I'm always on Simple QI. But this is our project homepage. But I will show you, this is what you're going to see as a team. This is my test team. This shows you what the aim is of the project. And again, you can edit this. I can say, you know what, I want to say I'm going to achieve, 75% by Q2 or something. So you can change it, but we want you to keep the general aim as well. But if you want to add something in, you're welcome to do that. We encourage you to do that. One thing I really want you to focus on after our huddle today is creating your team. So you'll see I have no one on my team, so that's pretty useless because you want to have a team built. So you'll just go here and add a member. And let's say I want to have Anastasia on my team. She's a good person to have on my team. I want to make her an administrator because I want to make her in charge of everything. So I'm just going to add her in. I'll invite her, and then it will send her an invite and say, hey, Anastasia, you've been invited to this team. Let's say I also want Tanika on here. And I want Tanika to be able to enter in data. So I'm going to make her a contributor to this team. So to enter in data, someone will have to be an administrator or a contributor. I recommend you only have 1 to 2 administrators because they can actually edit things. But guests and key contacts and viewers, they can't necessarily enter in data. So just make sure you're aware of that. And then also make sure anyone that you're inviting, you want them to be able to see your data. They're going to be able to see the data. So don't invite anyone that you don't want to have see the data just yet. The other thing is that you can enter in, so all the measures for the project are right here. You'll see this is optional. You can enter in data at any time. So I can enter in multiple measures at once, or I can just enter in one at a time. So if I go in here, I cheated, I already entered in some data. So let's say I had 150 LPIs for the month of April, or sorry, the month of March, and 50 of those had the discharge readiness checklist. So I would just enter in a 50, 150, and then it automatically calculates it for me, and it tells me what my goal is, but it also tells me where I'm at. Let's say for May, we did a little better and we had 75 out of 200. Well, that wouldn't be better. Let's say we had 75 out of 100 and we suddenly spiked up. And what did we do? So I can write in here in my annotation and say, we rolled out the implementation plan. So make sure you annotate things if you want to see what's going on your graph, and then you'll be able to download the graph. I'll get more into detail on all of that. I really want to show you how to enter in your data. For the structure measures, again, you're only going to be doing that quarterly. So let's say I want to update that I have a patient family partner. So I'm going to say for Q2, we haven't really done anything. We don't have a patient and family partner yet. So unfortunately, I'm at 0 out of 100%. And I'll just say in the annotation, we're working on this. And then there you are, you're all set for that quarter. Just make sure you're selecting the appropriate quarter or the month. There are multiple ways to enter in data. I won't belabor it too much, and we will have that lovely YouTube video that we'll be developing with Anastasia on entering in data and doing your status reports. But you also have the option here of entering it in all at the same time. So you could say, okay, for let's say for April, and this is broken down by race and ethnicity. So let's say I had 5 out of 5 Hispanic infants were discharged with a discharge readiness checklist. Let's say 3 out of 4 Medicaid infants were discharged with a readiness checklist. So it automatically populates that for you. And then you have your overall number, 50 out of 150. I can also do my process measures all at the same time for April. So this is a really nice and easy way to do it as well. And then you can go in here and enter your quarterly data. Just make sure you always put 100% for your denominator. You can say 50 out of 150 if you want, but it's much easier if you think of it as like 100%. You can also copy and paste data, but that's kind of more challenging. So I'll get into that if you all want to on the video. But it's a really easy tool. I can go into this and show you more, but I don't know how much time we have. Again, Anastasia mentioned resources. You can have team resources and project resources. Anastasia's already uploaded this for all of you in the project resources. So you've got your toolkit, your website, your project infographic. Everything's there for you and your team. And you can also share it with your team. You can have discussions between your team. We'll have project discussions as well. Lots of opportunities for doing things in here. As Anastasia said, the key driver diagram is already in here. So that's ready for you to use. And also you can do your PDSA cycles based on that. So we'll get into that later, but it's a really easy, they call it Simple QI for a reason. It's a great tool. We encourage you to use it. And, you know, again, entering in your data is pretty seamless and easy. And overall, this is hopefully a pretty simple project, and the data that we're asking you to collect is pretty simple. But of course, you know, this being a pilot, we're willing to work with you on that. And, you know, if there are any challenges, please always come to me. I'm an email or a call or anything you need away. I don't know if I have other slides, or Anastasia, is there anything else you want me to cover here?
When can people expect an invite to Simple QI?
Yes. After your application is complete, Anastasia will be sending you a welcome email. And then after that point, I will open up Simple QI to you. So look out for that after your application is complete. And I will usually just put in your data contact and your day-to-day person, and then I'll leave it up to you to build your own team. I won't enter everyone in there unless you request me to do so. I'm happy to do so. Just let me know what you prefer. But I like letting people build their own team and giving them that option. I will stop sharing. Any questions on Simple QI? And again, if you're like, I didn't get any of that, Alicia, I need a one-on-one, I am happy to meet with you. It'll take me, we'll have a 15-minute meeting. I have some slides in here, but we can go past all of that. That was just to kind of show you all, but I kind of already did that. So just a reminder, after you get your application complete, you'll be sent a baseline survey. Please take that survey. That just tells us where the teams are starting at on everything, and it shows us where we have to go and what we can focus on in the huddles. So it's really useful. Make sure you sign into Simple QI specific to the LPI project. So you may see multiple projects if you've been involved in projects in the past. This is just going to say late preterm, and you just click on that one. Create your team as we discussed, and of course, always send any questions or feedback to us. And again, resources, I'll be putting the data collection guide in there. I didn't see that in there yet. As Anastasia mentioned, this toolkit, this faculty is so amazing. This toolkit's amazing. I'm super excited about this project. There are videos and tutorials in Simple QI, but Anastasia and I will be creating some of those as well. The huddle slides will be in there. And then also, please remember, we are a resource and the faculty are a resource. And again, they're an amazing group. So please always reach out to us with questions. So Anastasia made this beautiful timeline, so I hate to take credit for it, but really we're going to ask you to start collecting data in May, but you're not going to have the infants discharged until the end of the month. So we're going to ask you, okay, all the infants born in May, how many of them had a discharge readiness checklist? And it may be 0%, and that's okay because you're not up and running yet. That's okay. So the data collection will officially have started May 1st, which I realize is, 5 days ago. But we'll expect you to have that monthly data in by June 8th. So we'll give you like a week of time to kind of get it together and be like, okay, this is my data for May. And then your quarterly data, like I said, that's only due every quarter, of course. We'll have you have that in by July 8th. If you need a little more time, it's okay, but we'd like you to get that in as soon as possible after the quarter ends, which would be July 1st or June 30th. Any questions on that? Oh,
Sorry. Same page. All right. Thank you, Alicia.
Sorry, I just realized I could leave the slides, Anastasia. I'm sorry about that.
Oh, you are good. So next steps, what do we go from here? So I would say our first step is to schedule a coaching call, regardless of where you're at in your application, whether it's complete, just started. Let's just get a time on the calendar where we can meet for about an hour, discuss what we need to do. We just presented you all with a lot of information. So if you're feeling overwhelmed, that's okay. We can get some time on the book, figure out what we need to do and what to focus on. So just email me a few times that work for your team, and then we can get something on the calendar. And then a few upcoming dates and next steps. So in addition to scheduling your coaching call with us, we'll want you to prioritize completing your application in REDCap. If you haven't already done so, you'll just have to designate your different project team members, and then each of them have to sign electronically. So it's a pretty simple application process. And then depending on the last data usage agreement that you signed, you may need to update that, but I will be in touch if you do. And then our next pilot huddle is June 2nd at 3 o'clock Central, 4 Eastern. So you can expect an invite from me after this call. And then to complete your baseline survey, which will be sent after you complete your application. But just a reminder, our statewide kickoff is July 7th. So any feedback you can provide before then is super helpful as we prepare for a statewide launch. And here are those tentative dates for our statewide huddles as well. So July 7th, August 5th, September 2nd. But let's get started. Let's get going. I'm excited to launch this project with you all. We are here for however we can support you. So let's get a coaching call scheduled and get going on it. Any questions that you all have? This was recorded, so if anyone didn't make it on your team that you really wanted to be here, I'm happy to share it with you and they can watch it. Any comments from our faculty or any closing notes?
I'm just excited to get going. I think it's going to be a great project as we've been preparing the toolkit and looking forward to this. There's been so many times I've seen babies and thought, oh, wow, I really wish, we could do this with this baby because I think it would make a difference. And yeah, I'm excited to see where we go with it.
All right, well, if you want to take our post-huddle survey, let us know how we can improve, or if you have suggestions for future huddles, we always appreciate that. But I hope everyone has a great rest of your Tuesday. Thank you for being here with us. It looks like Brenda.
Yeah, I just want to thank everybody. It's really exciting. And any way we can help, reach out. So thanks, everybody. It's great to see you.
All right, have a great day, everyone.
Thanks. Bye, everybody.